So thank you. So it's my role to try and put this into context. So just to remind ourselves that ovarian cancer is the 8th commonest cancer in the world, with 295,000 women being diagnosed and over 185 deaths. So the issue with ovarian cancer is that the majority of women relapse, and that's the real issue. So 70% within 3 years. And the 5-year survival for stage 3 is 20%, and for stage 4 disease, 5%. So PARP inhibitors have revolutionized the treatment landscape of ovarian cancer. PARP inhibitors, so olaparib, which we've heard about, niraparib and rucaparib, are approved in recurrent ovarian cancer and have been shown to improve the progression-free survival. But if we're really going to have a chance to increase overall survival and hopefully more women cured, we need to bring these treatments into the first-line setting. And here in this presidential symposium last year at ESMO, and in this press release, you heard me talk about the results of the SOLO-1 trial. So the SOLO-1 trial has changed the landscape of first-line treatment. This was presented at ESMO's presidential session last year and published in the New England Journal of Medicine. And what that showed was that for women with BRCA mutations, following chemotherapy and having had a response, to then have maintenance olaparib for a 2-year period. And what we saw there is that the women, compared to placebo group, which was standard of care, that they had a hazard ratio of 0.3, which translated to a median progression-free survival of over 3 years compared to the placebo group of 13 months. So what does PAOLA-1 and Isabel Ray-Cockart study add? And what else are we going to hear during this congress? Well, there are 3 studies in first-line setting presented in today's presidential session. You've already heard the results of PAOLA-1. There's also the PRIMA ENGOT-OV26 study and also the VELIA study. Now, the key questions for me as a clinician and a trialist is how can we improve on the results and the standard of care that we've had so far? So the main questions are, can more women benefit from a PARP inhibitor in the first-line setting beyond those women with BRCA mutations? And we've eloquently seen from Isabel Ray-Cockart that that is possible. So the next main question really is, if patients can benefit beyond patients with BRCA mutation, how can we best select which patients are going to benefit for the longest time? That brings in the concept of HRD deficiency. The other question is about, can we improve by combining treatments? So, for example, you heard in PAOLA-1, olaparib combined with bevacizumab. So taking those 2 main points, the PRIMA-1 study was looking at niraparib as maintenance treatment. So just like what I said in SOLO-1, no combination, maintenance treatment alone, but with the PARP inhibitor niraparib beyond women with BRCA mutations. And the key point there is, just like what we've seen in PAOLA-1, is that we've got confirmation that more women can benefit from PARP inhibitors. So we also see that with the VELIA study, which is a US-led study, which is looking at combining PARP inhibitor veliparib with chemotherapy at the same time together, and then having maintenance veliparib. And you'll hear the results later on today, but essentially that shows that chemotherapy with veliparib and veliparib maintenance therapy is better than no PARP inhibitor alone, and that's been shown in patients with and without BRCA mutations. So the real questions, I think, are, we know now, for the end of today, the presidential sessions, that we can use PARP inhibitors in the first-line setting beyond women with BRCA mutations. I think the key question really is, what about patients that don't have HRD deficiency? We do know that patients with BRCA mutations and that are HRD positive have the greatest benefit from either a PARP inhibitor alone or indeed in combination with bevacizumab.